Thank you. Thank you so much for inviting me. Thank you, Aggie, for giving me a privilege to present some of our data to this August group. I want to really start with thanking Aggie Hirshberg and Hirshberg Foundation for doing an amazing job for the last 12, 15 years. As all of us know, this is the 10th celebration of the Pilot Awards. And the reason I'm here and I'm showing this is because I am one of those 100 or, Pilot awardees, about 50, how many of them you have given, Aggie. And hopefully you will appreciate that how a small pilot award can make a big difference. At least it made a difference to me, and I'm hoping that it will make a difference to many more patients we care about. Thank you, Aggie. Thank you, Hirshberg Foundation, for this. So I don't have to convince this group that the diseases of the pancreas, both pancreatitis and pancreatic cancer, have very significant morbidity and mortality. These two diseases cause really a havoc for a large number of people, millions of people worldwide. Even in our country, every year, more than 300,000 patients are affected by pancreatitis, and pancreatic cancer are pretty grim statistics. Our work for the last about 15, 20 years has spanned looking at heat shock proteins. These proteins were discovered in 1962 by an Italian scientist named Ritosa, quite serendipitously, as most of the research happens. And since then, there's a lot of work on heat shock proteins in every possible cell and every possible disease you can imagine. These are very ubiquitous proteins, whether it's plants, bacteria, animals, humans, rats, mice, everyone express these proteins in response to stress. These are very interesting proteins, very exciting. That whenever we have a sublethal stress, these proteins go up, and then it prevents subsequent stressful things. Subsequently, when events which can kill the cells, these proteins protects them. So this is just an example. We started our work about 15 years back working on heat shock proteins in pancreatitis. Actually, most of our work is in pancreatitis. I'm relatively new to pancreatic cancer, and again, thanks to Hirshberg Foundation, that our interest has now shifted probably predominantly in pancreatic cancer. We still do things in pancreatitis, but it's a lot more in pancreatic cancer. So here is an example where we had made these transgenic mice and which overexpress HSP70. If you look at these wild type mice where we induce pancreatitis, as expected, there's a lot of injury, inflammation, necrosis, cells are dying, but when you have transgenic mice, the cell death is much less. Just to quantitate that, and this is the only slide I'll show you for pancreatitis because this is Symposium on pancreatic cancer. So you can see here, whether you look at MPO activity, which is a marker of inflammation, which goes up in pancreatitis, and in transgenic mice is much less. Same thing happened. You look at necrosis. In pancreatitis, cells die. That's why we have necrosis. And you see in wild type, there's a lot of necrosis, whereas transgenic mice, which overexpress HSP70, has much less. I'm going to summarize this work on pancreatitis with one of our favorite slides for our group. I'm sure most of you have seen this before. So if you take a acinar cell and cause insult, which causes pancreatitis, whether it's a cerulean in animals or gallstones or drinking too much or whatever causes pancreatitis, the cells, acinar cells die. That's what happened in pancreatitis. But if you kind of preload them with HSP70, and there are many different ways of doing that. I showed you the transgenic, but you can heat them, you can cool them, you can water immerse them, you can do whatever. There are many ways to get stressed. And when you stress them, this HSP70, the green proteins, not that they are green, but they are good, so we make them green, right? So cause the same insult, cells live. All of this tells us that HSP70 really protects cells from dying. And in pancreatitis, it's a good thing that we protect cells from dying, and that's why we call them angels. because they are protecting you. But remember, what looks good sometimes is not quite as good. Something which is nice one day could come and bite you. And that's what we're going to show you next, that the same good green protein really turns out to be a big culprit for pancreatic cancer. Again, I don't have to convince you that the pancreatic cancer is the most lethal disease, and I want to use my favorite term, to humankind, not mankind, because it's one of the very few things which are totally discriminatory, non-discriminatory. It hits women as much as it does to men. So it really is a very, very bad disease. Worldwide, this year, almost 300,000 patients will be diagnosed, and unfortunately, no one will really survive, really survive. Why is that? Because we don't have any therapy, really, because the tumor cells don't die. We had gemcitabine for the last 15 years. Gemcitabine added 6 weeks. Without this, median survival 4.5 months. With this, 6 months, 6 weeks more. We have a new drug which I didn't list, Abraxane, which just got approved. Fortunately, it will add 2 more months. But just think about that, 2 more months to our life. So why are these things, why these tumor cells don't respond to anything? Well, remember I showed you that these green proteins, which at least we call them green proteins, they are not really green, that they protect cells from dying. So about 8 years back, when we started thinking on pancreatic cancer, we knew that HSPs protect cells. Then we thought maybe the tumor cells have too much of these good things, these angels, right? And that's why these tumor cells don't die. We want to kill them. Unlike in pancreatitis where we want to protect them, here we want to kill these cells. And these proteins are protecting them from killing. That was our hypothesis, that little angels are really not angels, they are devils. Is it really true, or is it just our feeling? Here was the very first experiment we did. We took 4 different pancreatic cancer cell lines, compared them with normal duct cells, which we got from Dr. Anil Rustagi. You can see all of these are much more. You don't have to be scientists, you don't have to be statistician, you can tell this is a lot more than this. But having something more in cell lines is not as relevant. It's important, but not as relevant. Really thing is what happened in patients. Here is the data from fresh tumor resected in patients, got it from OR, and you have a normal margin, and the tumor, you can see compared to a normal margin, tumors had about 20, 30 times more HSP70. That validates that what we are doing in cell lines is really valid. Well, with these findings, our hypothesis became that if this is true, if we are right that these proteins are protecting cells from dying, then blocking these proteins, HSP70, should kill tumor cells. Very simple. Very, very simple hypothesis. Except there was a problem, and it still is continuing, because there are really no known good inhibitors for HSP70. So we've been trying many. And then in about 7, 8 years back, we found this compound, triptolide, which comes from, this is the diterpene, this is the structure, this comes from this plant in China. They call it thunder god vine. And in China, it has been used for many different things. If you look at the literature, there are probably thousands of papers on this. Last 100 years, because in China, it's used to cure arthritis. It's anti-inflammatory. And there's literature that it can also kill tumor cells, all kinds of tumor cells, in crude form of triptolide. We were the first one to show that triptolide is a very, very potent inhibitor of HSP70 in tumor cells. These are Mia-Paca tumor cells. You can see in nanomolar concentrations, it's killed tumor cells. Not only it kills tumor cells, it inhibit tumor, HSP, it kills tumor cells like crazy. At 50 nanomolar concentration, most of the cells were gone, whereas the normal duct cells had very little effect, if any. Well, killing tumor cells in a test tube is very simple. I always give my favorite example. we could put a little bit of bleach, or if you like sulfuric acid, you can put a drop of that. It will kill every cell. But more important is what happened in animals. The small animals, which we are going to show you right now, and then eventually the big animals, us, that what really happened in that. That's what's important, not in cell lines, but you have to start with that. So here is the data in mice. This is the orthotopic model where we injected these tumor cells into mice. They grow in about 60, 90 days. 90 days, they were big tumors. You use triptolide, very low dose every day, and you can see the tumor was almost gone. These results were published by Phoebe Phillips, who was our postdoc, came from Australia, from Minoti Apte and Jeremy Wilson's group. She got PhD with them, and now she's back. I think she was here at least yesterday. I don't know if she's here today, maybe at the beach, but Phoebe did this work, and we published that in Cancer Research in 2007. That's the time I moved from Massachusetts to Minnesota. There was a lot of interest in this, and the university and the medical school, our cancer center got excited. But there were problems with this. We wanted to take that to the clinic. What was the problem? Well, it's soluble only in organic solvent. DMSO, 100% ethanol. Giving IV 100% ethanol might be fun for a couple minutes, but after that, it becomes a little bit problem. So, and the big problem was, which is unfortunate, but a practical problem, that triptolide didn't have a patent. No, you cannot get intellectual property rights. So that means no drug company will ever work on that. And these are drug companies which can only sell drugs. Universities cannot. So we worked together with our medicinal chemistry department, Dr. Gunda Gyar, and we made triptolide to a water-soluble prodrug, which we called Minnelide, from Minnesota, and light comes triptolide. And a couple of months back, university was granted a patent for this, and I'm part of that patent. And there's a disclosure that this compound has been licensed from university, which holds a patent, to a startup company, which I'm one of the co-founders, along with Dr. Velgapudi. He should be here in the back. And we named a company Mini Amrita. And this relationship has been approved by the university and managed by this. So here is the first data on Minoloid. Look at this mortality data in mice, same kind of a model I showed you before. When you don't give Minoloid, all the mice, as expected, die. People die from pancreatic cancer. That's the disease. So you can see that only 1 mice out of 10 survived in 95 days. But if you look at all of this, different doses of Minoloid, all of the mice survived. Why did these mice survive and this not? Because look at the tumor burden. This is vehicle-treated mice, big, huge tumors. When you use the optimal dose, tumors are almost gone. That's why they live and they don't. Very simple. Well, I'm sure all of you are fully aware that the pancreatic cancer comes in different forms. Some patients, unfortunately, with pancreatic cancer survives only 2-3 weeks, just 2-3 weeks post-diagnosis. And some lucky ones live 2-3 years. So the aggressiveness is very different. We don't know why, but that's the case. And these cell lines which are derived from these patients have the similar kind of profile in aggressiveness. So the data I've showed you at MIA-PACA cells so far is moderately aggressive. These mice lived about 90 days. I showed you the data. ASPC is one of the more aggressive cell line. Here, the mice, if you don't treat them, they die in about 45 days. Median survival is 36 days. But the ones which were treated with Minnelide, look at this line here. They lived forever. Well, in mice case, that ever is about 2 years, and we got tired of injecting them and treating them after about a year. But even when we stopped giving the drug after 100 days, they lived. When Veena started these experiments much later, that is when first mouse was dead with tumor burden. You started treating them with Minnelide. Again, untreated ones, as expected, died. The treated one, and remember, here we started treatment when they were well-formed tumor. Actually, we randomized them after first mice died from tumor burden. So you can see even there, these mice survived. The last data I want to show you in these cell lines is the most aggressive tumor cell line we know is S2013. And these mice die in about 30 days. And they were pretty bad, actually. If you look at these mice, they look pretty bad. And these are the saline treated. But the ones which are treated with Minnelide, they were pretty happy campers. Actually, we had to sedate them to take picture. Now, in general, it's difficult to take picture of mice anyway. So, and why the vehicle ones were unhappy and they were happy? Just this data, look at these. Every organ you can imagine with these cells were metastasis. And the Minnelide treated one, now you know why they lived. There was no metastasis. Well, treating cell lines, again, I come to the same thing, is one thing. But the real thing is what happens when you take patient tumors. Obviously, eventually, which I'm going to end my talk with what happened in real patient. But here, again, we got fresh tumors from the OR, xenograft, put them in mice, the tumor grew, and these are the experiments done by Veena, who's here, and this tumor grew. But when we treat them with Minnelide, you can see not only tumor didn't grow, it went away. Even when she discontinued treatment, the tumor was gone. But more importantly, when this tumor was that big, right here, rather than sacrificing them, she started treating them. Right here, see what happens. I almost wish that we had a video camera and we could do time-lapse video, because every time you go and you can see tumor is decreasing, decreasing, and gone. She repeated this experiment. This time started when the tumor was pretty big. It grew bigger, but when she treated that, you can see this is our regular dose. Even when you use half the dose, the tumor was gone, took about 20 more days, but it was still gone. All of this convinces us that that's pretty effective in getting rid of pancreatic tumors. Remember gemcitabine? We did Rohit did head-to-head comparison. You can see compared to gemcitabine, which, as we know, adds about 6 weeks. Small difference, Minnelide really works. This work on Minnelide, we had a first paper in Science Translation Medicine almost a year back in October 2012. And since then, we have several other studies on Minnelide in many different cancers just published. Actually, and in our university, many different groups are trying in almost every cancer you can think of. They're trying the effects of Minnelide, and it's effective in several different cancers. So what I've shown you, and I'm going to spend 5 more minutes showing you the mechanisms that how really Minnelide or triptolide is working. So what I've shown you is that it inhibits HSP70 and causes cell death, but the question is how HSP70 inhibition causes cell death. I'm not really going to show you the data because you'll see that why, because it's published about 3 years back, that what Vikas in the lab have shown that triptolide inhibits HSF1, which is a transcription factor, which inhibits HSP70, causes lysosomal membrane permeability, causes increase in intracellular calcium, and that's what causes tumor cell. So all of this is published by Vikas Dudeja, who's now used to be a surgical resident, worked in the lab, and now he is doing a Surg-Onc fellowship at Memorial in New York. And this is some of the work he did when he was in the lab. So what I've shown you, or not shown you and told you, is that the triptolide works like this, HSF, HSP70. The next question we asked, how triptolide inhibits HSF1? For that, we went to look at what happened to NF-kappa B. NF-kappa B is a transcription factor for inflammation for many different things. And in pancreatic tumors, it's already known, published, but this is our data which tells you that in almost every possible scenarios, whether you take cell lines, KPC mice tumors, or patient tumors, NF-kappa B is upregulated. What Sulagna in the lab showed is that triptolide inhibits NF-kappa B. So triptolide is decreased, NF-kappa B is up in pancreatic cancer, triptolide is inhibiting this, whether it's constitutive or TNF stimulated, triptolide decreases that. And so what? Then in another experiment, she showed that if you take a specific, relatively specific inhibitor of NF-kappa B, this compound BA11785, that you can see in a dose-dependent fashion kills tumor cells. So you know that NF-kappa B is killing tumor cells, and triptolide is inhibiting NF-kappa B. So that convinces us that triptolide works by inhibiting NF-kappa B and kills tumor cells. In the next experiment, she shows that triptolide also inhibits HSF1 and HSP70, putting together. So now our story becomes that triptolide inhibits NF-kappa B, which then inhibits HSF1, HSP70, and causes tumor cell death. Very logical extension of the work. The other pathway which we looked is ER stress, which is totally uncharted territory, that how triptolide upregulates chronic ER stress. I'm just going to show you one slide on that. We have a lot of work on this, that triptolide, you look at any possible parameters for ER stress, all of them are up. And we have a lot more data, but lack of time, I'm not going to show you. So what we are saying is that triptolide is really upregulating ER stress. High ER stress, chronic ER stress is bad, and it causes cell death. And some of the exciting data we have is that ER stress causes lysosomal membrane permeability. Just one slide, tuncomycin increase ER stress, and tuncomycin also increase cytosolic cathepsin B, lysosomal membrane permeability, and this is what kills cells. So the story becomes now that triptolide is causing increased ER stress, NF-kappa B, and causing cell death. The questions never end, right? So next question is how triptolide is causing ER stress or NF-kappa B, and that's where the exciting story we have is that we think that triptolide works primarily by inhibiting SP1. And SP1 is a large transcription factor, it's very ubiquitous. It controls about 12,000 genes, and it's there in the development, but in the adult pancreas, it's normally not there, but it's highly expressed in gastric tumors. Here is the data on pancreatic tumors. You can see this is from human patients, and this is our data in all the cell lines, which Saluja did. You can see it goes up. So if SP1 is up, again, now she used triptolide, and you can see a beautiful dose-dependent decrease in SP1 activity. So what we believe now is triptolide's real effect starts with inhibiting SP1. And if she inhibits SP1 with siRNA or mithromycin, another inhibitor of SP1, cells die. So all of this brings us to this, that triptolide inhibits, kills cells. It does so by inhibiting HSP70 through intracellular calcium and lysosomals. It inhibits HSF1. All of this I've shown you, NF-kappa B, ER stress, and then it does so by doing SP1, and this is kind of one of our hypotheses right now, that that's what we think how triptolide is working. Our lab is now studying how triptolide inhibits SP1, ER stress, or NF-kappa B. These are the three aims of our recently funded R01 grant in this area. I'm going to take just one more minute and show you last two slides, which we are very excited. This is our new unpublished work. So we are going to show you the effect of Minnelide on cancer stem cells from the pancreas. So we separated stem cells, Saluja did, by a marker we use. There are several stem cell markers. The one which is our favorite in the lab is CD133. And there's some other cancers. Some other people have shown that CD133 is a stem cell marker. You can see that from MIA-PACA, we can isolate stem cells. And these stem cells, when you see the CD133 positive cells, when you put them in mice, tumor grows in CD133 positive, but not in CD133 negative. This is the tumor growth curves. But this is the punchline here, that when you use this CD133 positive cells, put them in mice, the tumor grow. But if you start treating them with Minnelide, you can see the tumor goes away, whether you look at a tumor volume. And there are two different ways of making these CD133 cells. Either which way you make them, you can see the tumor vanishes from that. So these are the tumors which are initiated by stem cells. And if you look at the tumor weight and tumor volume, again with Minnelide, that was all gone. Then Saluja went ahead and isolated the CD133 positive stem cells from genetically engineered KPC mice. This is the first report that you can make stem cells from KPC mice. And these mice are very aggressive because they have a lot of CD133 positive cells, a lot more than whether it's a MIA-PACA or any other system, any other cells we have used, even more than clinical patient tumors. They have about 8 or 9% CD133 positive cells. And when these cells isolated from KPC mice, and this is absolutely the last data slide, you can see here that the cell viability of these CD133 positive tumors, stem cells isolated from KPC mice, triptolide kills these, whereas gemcitabine, which doesn't work, does not kill these. And the cell death is via caspase 3 activity. You can see again, triptolide is inhibiting CD133 positive cells, increasing KPC, whereas that does not happen with gemcitabine. So in summary, CD133 positive is a tumor-initiating population in all kinds of pancreatic cancer stem cells, which we have isolated in our lab. These tumor-initiating cells have increased expression of stemness markers. They are tumorigenic at very low cell concentration. I haven't shown you that. But the more important, Minnelide reduced CD133 positive tumor-initiating population, both in vitro and in vivo. Well, the most exciting news for us also, I've been waiting for this, to show you this slide for last 7, 8 years since I started working in pancreatic cancer. And I am so excited and happy to tell you that last July, FDA approved our phase 1 trial, and it's ongoing now. We started the trial a couple months back, and we already have 3 patients enrolled in the trial. The 4th patient will be enrolled on Monday, and 8 days later, that's the requirement by FDA, we have already lined up 2 more patients to be recruited. We are expecting the phase 1 trial to continue for another 9 months. And I'm waiting for and hoping with all of your prayers and best wishes that we will be able to make a difference in this. I want to acknowledge everyone who really contributed. I'm really a presenter. I have a great team of almost 20 people who have contributed to this work. And actually, most of them not as dressed up. This picture was taken last year in this meeting. So. And I really appreciate the funding. As you can see, the Hirshberg Foundation provided a pilot for this. Once again, thank you so much, Aggie, for doing that. Thank you. Well, before we go to Raul's question, I really want to show which has become my passion and my favorite slide. This is I imagine a lot nowadays, and you imagine that you can make a difference. I think all of us need to imagine this is a dreadful disease. In last 30 minutes, remember, in last 30 minutes we are together in my talk, 3 more Americans. If you don't care for the rest of the world, just care about Americans. 3 more Americans died in last 30 minutes. Worldwide, 300,000 patients will die. 300,000 human beings will die. Imagine we can make a difference. We need to work together, and that's what Hirshberg Foundation is doing. Thank you.